I love dislocations, and they're fun to do, and we're going to talk about a few here. I find these very rewarding. Occasionally, they can stump you, and you can't get them. I like to do them as much as possible without all the headache of procedural sedation, but having noted that, there are some times when that's just not the right thing to do. You should give them the meds. So let's go. Very satisfying. As I mentioned, failure can look frustrating. Good technique and good skills in this make a real difference. And we'll talk about some unusual dislocations that can perplex along this talk. Here's one you see every once in a while. Someone says, I was eating a hoagie sandwich, a little East Coastage for you, or they yawned, and this is what happened. And they have what seems like a unilateral sort of out-of-place jaw, and they can't move it. They have trismus. There's usually no fracture. There have been several papers that say if it's an atraumatic mechanism, you can proceed directly to relocation techniques. You don't need to get films on them. Obviously, if there's trauma or if there's severe pain along the condyles or along the bony prominences, then you can consider it. They often have excess salivation, be drooling a little bit, and they do not look like they're happy. So we want to put that back in. What I usually do with these is I don't do procedural sedation. I give them 5 Versed IM. Boom, no IV, no nothing, right away. Can I have 5 Versed? Bam, IM. It's going to be rapidly available, rapidly absorbed. There are a couple of different ways. I put pads on my fingertips, and I'm going to try and get into the back of their mouth as shown in these images and push down. If you have the patient right in front of you on an exam table, you don't have good leverage. They're too high. So make sure either you're very tall or the gurney's very low so that you're like this. Or better yet, I find I like to have the patient seated right in front of me, right here, looking at you, and go the other way, from behind. Now I'm reaching over their shoulders, into their mouth, and that gives me excellent leverage down. Plus I can just kind of lean on them and be steady. Remember, you got to kind of dislocate them more before it will relax back and come in. So those are some neat techniques for that. So I like it seated. I like the 5 Versed. You can go for a little light sedation if that's not enough, but I don't like to do procedural sedation here. Definitely pad your fingers. As with all dislocations, it's about steady pressure, not intermittent hard pressure. I see people pull really hard and then relax, like when they're doing a shoulder. Pull really hard on an ankle and then relax. No. It's steady pulling that will overcome muscle spasm. So that means that you, as the person doing the reduction, need to be comfortable enough to maintain steady force. You have to overcome pterygoid spasm on this, and it will work. I just have to mention it just because I've got a new technique on this that I was taught by one of my graduates, and I've only done it once now, but he says he's done it 10 times. The time I did it, I liked it. So here's what you do. You take a stack of 7 or 8 tongue depressors, tape them together, put them in the person's mouth, tell them to sort of bite down on that. Then you give them about 5 more tongue depressors. You say, whenever you can, stuff another one on the pile. They keep adding them. They keep opening. And what happens is it overcomes their pterygoid spasm, and then when they can take them out and it's in, you're done. So it's not always that beautiful, but I have seen it work that way, and it's pretty nice. Failing that, the rest of what I said here. All right, clavicle dislocations. This is a little bit uncommon one, but every once in a while you'll see them come posteriorly or anteriorly. The posterior ones you got to worry about a little bit more, and they're very uncommon because right behind that is the subclavian vessel. The anterior ones are a little more common and a little easier to deal with. So what do we do with these? And so with a posterior sternoclavicular dislocation, the first thing is to remember that I got to think about their vessels. You might worry about what their vital signs and things are. Is there bleeding, evidence of a hematoma? In the absence of those and the absence of a fracture, I think you can go right away. If it's not benign, there's anything worrying you, stop for a second and CT them first, CT the chest. But if everything looks good, you can move to reduction, and closed reduction is the way it goes, and you might want to have some towel clips handy and numb up the region of the proximal clavicle. And so here's a couple of x-ray views that you can get to help you diagnose it. that are special views. The serendipity view is up top and the Hobbs view is down at the bottom. And they may help you, but usually you can tell basically from clinical exam to confirm what you're doing. This is an apical lordotic that shows you one. The serendipity view shows you that that clavicle on the patient's right is out. So here's the approach. The first thing I like to do is get that towel between their clavicles. See the towel on the gurney? Let them sort of sag around that. You want it very high in the midline. It's not all the way across their back. It's just resting in the center of their spine. That gives me a little room to push their shoulders back to the table. And that'll often open up their chest and pop that back up. And if that won't go, you can do a little bit of what we're showing over on the side of this film, where you directly sort of push and pull that shoulder out. A lot of times these go in with a very satisfying pop. I like doing these. They're not that common. When you get one and you get it right, though, you feel pretty good about yourself because it's an uncommon dislocation. Medications for this depends on what the situation is. This is another situation where I really like 5 milligrams of Versed IM 5 minutes before I start, 10 minutes before I start. That doesn't require me to get all the crazy paperwork done or any of that other stuff. It allows me to move relatively quickly. It often also gives me a little power of suggestion. The patient's got that Versed on board, so I can tell them, take a few deep breaths, start relaxing, a little gentle pressure on the shoulder, a little gentle pressure on the arm. Take a few deep breaths, relax, let it go. You know, you can do your whole rap. Tell them to think about their, whatever they, om. Visualize the joint going back, om. You know, you can really have a little power of suggestion with that Versed. Without Versed, no one will listen to me. Here's another move called the abduction of the associated arm. So you bring it out into the neutral position and start pulling on it a little bit. This is a lot like what's called the fast, reliable, and safe shoulder relocation technique. What you're doing is you're getting the arm into zero position. The nice thing about zero position is when you pull on the arm, you're pulling on the entire shoulder girdle, not just the arm. So that's going to give the room for the medial clavicle to jump back up. And if it won't go, the last resort is I numb the proximal third of the clavicle, I get a towel clip, I actually grab it through the skin, so they got to be numb, and then I pull on it directly. And I've only had to do that a couple of times in my whole career. Most of the time, just a simple towel between the scapula and a little gentle pressure with some suggestion, and they go in. So that's a fun one. All right, let's talk about rarer shoulder dislocations. So there's posterior shoulder dislocations, not real common, about 5% of the total. On exams, they always want you to remember that they're from electrical shocks or direct blows or seizures in particularly. And then luxatio erecta, that's the one with forearm to forehead, where they have an anterior dislocation with an extended arm. You tell them to put their arm down, they go, I'd love to, I can't. Come on now, help us out there, put your arm down. I can't. And it's locked up there. And then finally, posterior luxatio erecta, which is the rarest of all. All of these may have associated fractures with them. What do you want to know about these? And let me just tell you. There's some reduction techniques in common for all 3 of these rare ones. And the first thing to know is that scapular rotation is a useful adjunctive tool in relocating all 3. So no matter what else you're doing, if you can get the lateral board of the scapula and drive it towards the spine, even 4 or 5 centimeters, that's going to tend to enhance your relocation. The next thing about all 3 of these is they don't have a million techniques. Unlike anterior shoulders, where there's 25 different techniques to relocate them, the most common ones, these all require a simpler approach, which is inline traction and attempting to get to the zero position, which I already referred to. The zero position is, remember the anatomic man in the circle? That's the zero position. That gives you good so that's the position you're going to go for inline traction into the zero position, plus scapular rotation. And that will work on all 3 of these. Now, because these are a little more challenging dislocations, procedural sedation and analgesia will often be required with these. I rarely try these without it. So this time I'm going to need to consent them, start a line, pick an agent. If you want to go fentanyl Versed, that's fine. If you want to go with Brevitol, that's fine. If you want to do propofol, that's fine. Ketamine's not a great choice because it increases muscle tone too much. So I don't like ketamine for any of these. But fentanyl Versed pretty standard. I think that'll work just fine. Remember that after you get them in, you're going to x-ray them all up, and they can have Hill-Sachs lesions. A reverse Hill-Sachs happens with the posterior dislocations. That's kind of uncommon. These are all sort of rare entities, and that's why I'm presenting them to you. This is not your standard anterior shoulder dislocation. Axillary nerve issues are more common in all three of these, and so you really want to carefully examine the axillary nerve. Sensory over the deltoid region, as well as asking them to elevate their elbow and feeling the deltoid fire. I like motor exam of the axillary nerve better than sensory, but I usually do both. And here we see someone doing scapular rotation on the bottom of this image. See the scapula sort of outlined? And really, I don't like the way they're holding it. I often push both my thumbs on the very tip where her left hand is. I think that's a her. Where the left hand is, and drive from there, the scapula immediately towards the spine. And here again, what do you see going on with this picture? The arm is almost in the zero position with inline traction, and scapular rotation is being added to it. So this can be done in all three of those unusual, very unusual dislocations. Anterior shoulder dislocations I just love, and there's a bunch of reasons to love them. One, I don't know who determines how much we get paid for things. I think Greg Henry was at the meeting a couple years ago. But the number of RVUs for relocating a shoulder is high. You get paid as much for relocating a shoulder, any of these shoulders that I've been talking about, as you do for intubating someone. When I'm working, you can't get a dislocated shoulder off the paramedic gurney. I'm on it that fast. No shoulder, I don't care what I'm doing. Is that a shoulder? I'm on that. And usually the diagnosis is easy, right? Because the patient is there. You say, is that a shoulder? And the patient kind of looks at you, whimpers, and goes, yeah, your shoulder's out. They know what the problem is. You know what the problem is. Now you just got to fix it. So there's at least 20 low-force techniques here. You don't need to know all 20. What does it mean when there's 20 ways to do something in medicine? Either all of them work or none of them work. In this case, it's that all of them work if you know how to do them. And so I don't think you need to learn 20, but if you know a couple of different techniques, that's useful. We'll look at a few of the newer ones. Scapular rotation that I just discussed is my go-to move here, with no meds. You want to give the 5 of Versed, that's fine. But I can tell you that in a fresh anterior shoulder dislocation on a normal body habitus person, I have about a 75% success rate doing just scapular rotation with no medication. I was working at a place where Di and I used to work together, and this mom was there with her 15-year-old kid who had his second dislocation rebounding a basketball. So not really trauma. I wasn't worried about fractures. I hadn't sent him for an x-ray. I walked in the room, said hi, introduced myself to the mom, and she just lit into me. I was like, oh. And what she said was, he had this about 6 months ago. We came here. They tortured my child. They pulled on it. He screamed bloody murder. Then they had to start an IV. Then they had to give the medicines. It all took 9 hours. I'm not having that again. Want the specialist right now. And as Rick and Greg would say when you're faced with that, you always say yes. Yes, ma'am. First off, let me say I'm sorry that happened. I'll try and make sure it doesn't happen again. Of course we can get the specialist, but let me take a look first. So I just took a look at the kid. He hadn't even been to x-ray yet. I said, he was sitting there with his arm, and I went to his backside. I said, this doesn't hurt over here. Pushed it on the tip of his scapula. He says, no, that doesn't hurt. I said, let me just push this a little bit, and you just relax and take a few breaths. And I reached my other hand around and just rested it on his antecubital fossa for a little tiny bit of pressure. Boom, it went right in. So this is the exam. Mom's right there in front of me. And then she starts saying to me, I said, excuse me, calm down for a second. She goes, well, what are you going to do? I said, well, first, I think we should get some x-rays because I think I just put it in. She was like in disbelief. No way. I said, I asked the kid, can you touch your ear? He says, yes, feels better. So I went, he got his post x-rays, everything was fine. And I thought I was going to be her favorite doctor. When he got ready to go, I went back in the room to, say, all right, I'm glad everything worked out great and we didn't go through all that. She started yelling at me again. How come all the doctors don't know how to do that? Why did this happen like this the last time? I was like, ma'am, I'm sorry, I'm not in control of that. I can just do what I do. Anyway, there you go. So scapular rotation, I love it. And then we're going to talk about Cunningham and Ferries. Ferries is shown down here. Where are we going? We're going into the zero position. You get the arm out, and they talk about doing a little bit of a waggle up and down, maybe a little turning this way and that way for internal and external rotation. FARY stands for fast, reliable, safe. Simple way to do it. By the way, when you're getting them out to the neutral position, that can hurt. So go slow. Slowly externally rotate them. Slowly abduct them. What does that sound like? That's a technique right there. External rotation abduction, that's the hennepin. Here's the Neal Cunningham technique. I love the Neal Cunningham technique. He just, notice the position of the arm. It's externally rotated. He's sitting down next to his attractive dislocated assistant. And he's put his hand in the antecubital fossa just for a little gentle, persistent inline traction. He'll go up and massage the shoulder muscles a little bit and maybe push on the scapula if he needs to. That's the Cunningham technique. Like that, it works pretty well, particularly if you've got a cooperative patient. The Spazo technique I'm not such a big fan of, but I put it here just because people have heard about it and want to see it. It works. I far prefer scapular rotation Cunningham. This just shows you a bunch of different techniques, and the thing that I want to talk about here is that there are some high force techniques listed here. The Coker method, that's where after you get them out here, you do a snap of internal rotation to see if you can get it to go in. Don't do that. That snap of internal rotation is well documented to be associated with a snap of bones. So fractures are associated with that. The Eskimo technique also has fractures associated with it. So those are high force techniques. Scapular manipulation, you can see really good success rates, and that's why I'm there. Why do Eskimos dislocate their shoulders? Shown here why. They kayak. And they often kayak when they're hunting seals and things. And when you're near the shore, right, when a wave comes in, what are you supposed to do in a kayak? You're supposed to reach up with the paddle, catch the top of the wave, and do a wave brace and skirt along with it. There is no better way, right? This is the dislocate my shoulder position, right? And now I've added a leverage arm, a paddle, and just in case the leverage arm of a paddle wasn't enough, I'm going to add the force of the ocean to it. So that's a great way. Now, the problem with a dislocated shoulder in an Eskimo is that a one-person or a two-person kayak? It's a one-person kayak. So they're often hunting in pairs or in threes, but no one's paddling his ass home. So he's either going to freeze to death or paddle himself home, which means they have to get the shoulder in. So that's the Eskimo technique that's out of vogue. What you do is you lay him down. Here's his here's his head, feet down there. I'm straddling him. Then I gradually bring his arm up to this. What is that? He's in the zero position. Then I lift and let him hang by his own Eskimo weight. That's inline traction in the zero position. I let him dangle there. Let the spasm relax. Might even do a little swing with him. See if it'll go in that way, right? I'm going to get a little internal and external rotation. If it doesn't go, and here's the problem with the Eskimo technique, I step over with my muckluck, put it into his axilla and go, get in there. That's the part that causes the fractures. So the Eskimo technique is out. Coker maneuver is out, and the Hippocratic method is out. What's the Hippocratic method? That's where you put your stocking foot in their armpit and yank. So all those yank methods are high force, cause fractures, more axillary nerve injury, and they're dead. And since there's 20 other low force techniques, you should use them. All right, posterior elbows. I used to struggle with these. I used to do the top picture, or I used to do it with them laying in the bed, and you're pulling on the arm and hoping someone's holding the humerus, and you're sweating because it's not going, even though you gave them meds. And you're sliding down their arm, and you keep sliding. It's like a greasy rope, and you keep pulling and sliding, and it won't go, and you're leaning back, and it won't go. And you're like, geez, and these hurt, right? So they really need either deep sedation or they're howling. And then I learned a new technique, which I now do all the time, which is shown at the bottom, which is interlocking hands. I put here's their dislocated arm right here. There's their elbow. I put my elbow in the antecubital fossa, reach down, grab their hand, and now when I crank their hand up, my elbow is in their antecubital fossa and is a leverage point, and it puts their elbow in. I can show anyone who wants to see this outside how it looks, but this interlocking hand technique is now my way of doing elbows. I have not had it fail once since I learned it, which was about 20 elbows ago. It's great. And I've taught a lot of residents to do it who also got it right on their first try. And they're like, wow, that's good. And anyone who knows the old way and compares it to the new interlocking hand way is like, I'm never going back. I'm never going back. Make sure when you relocate an elbow, this is really important. We all say we do a neurovascular exam after a procedure like this. But usually with most dislocations, right, this circulatory status is improved after you relocate it, right? So we're a little bit cavalier maybe with it. When you relocate an elbow, you cannot be cavalier because it's well documented that you can catch the brachial artery and the median nerve in there, into the joint. And then they have really, they'll lose pulses and it'll be a real problem. When that happens, they have to go to the OR. It doesn't change whether or not you should have relocated the elbow. The real sin is not recognizing that that's what happened. So whenever you relocate an elbow, make sure to do a real neurovascular exam afterwards because it's a well-known complication. Even a casual search of PubMed will reveal people who've had disastrous outcomes because it wasn't recognized. This shows a coronoid process fracture where the arrow is. When the coronoid process is broken, that makes the elbow a little less stable, and there's nothing that'll piss you off, or me, I'll speak about me. Nothing gets me to the height of my pistivity more than having done procedural sedation, done all the paperwork, all the pain in the ass of doing that, putting the elbow in, and then it falls out while they're over an x-ray. If the coronoid process fracture is large, then you should take maneuvers to help increase this post-reduction stability. So instead of just putting them in a swath and sling like this, you should instead pronate them a little bit and hyperflex them a tad. That will increase the stability and help it not fall back out. And this talks about it. If the process fracture is too big and they stay unstable, then they're going to need surgery to fix that and restore bony stability of the elbow. Posterior hips, love posterior hips. Pretty common problem, knee versus dashboard, falls and jumpers. You want to get this hip in early because the longer it's out, the more avascular necrosis they get. So as soon as you're done managing your other trauma priorities, resuscitating them, maybe dealing with a chest tube, dealing with their head injury, whatever else you got to deal with, as soon as it's really physically possible, you need to get busy with the hip. Because leaving it out just means that they're possibly going to have their femoral head die, and then they're going to limp for the rest of their lives. That's not good. So there are a couple of the old ways here, the Alice and the Stimson technique. I don't do these anymore because they're really uncomfortable. I throw my back out, and every once in a while, well, let's just look at the central picture. I'm not saying that he has a head up his ass, but it's darn close. It's darn close. And so there are better ways to do this. This is not something I want to do. This is the Alice reduction technique. I have seen orthopods bang their head on the lights, and most impressively, I have seen once the whole gurney, patient, orthopod, and everything flip over. That's embarrassing. So for many reasons, I don't like this technique. What I like are the two new ways. On the left, you have the Whistler technique. We have the Captain Morgan, both sides here. The foot is up on the gurney, the leg is tossed over, and you're going to use your knee into their antecubital fossa, into their popliteal fossa, Your knee in their popliteal fossa creates a fulcrum. And you could go very steady with this, and with your free hand there, you can do a little internal and external rotation. And this works very, very nicely. That's the Captain Morgan. And this is the way I like to go, which is the Whistler technique. It's also referred to as over-under. The key part of this technique, which is not well shown here, is getting that patient's right foot, the non-dislocated foot, tucked all the way in up to their butt. The reason that's important is because it makes the kneecap of the undislocated knee as high as possible. And then when I reach underneath their dislocated leg and grab that knee, I have a better fulcrum. Here my forearm is in their popliteal fossa and the fulcrum. This technique, when I first, and it took me a while to figure it out, but once I was shown it and decided to try it again, we're usually using procedural sedation here. Brevitol is my go-to. You can use fentanyl, Versed, whatever else. But this really does work very nicely, very controlled. No one bangs their head. You're using, a lot of it is just standing up, getting the gurney height right. So here's my arm underneath the dislocated leg onto the kneecap. Notice my back is to the patient's head. So I'm there. Here's the foot of the dislocated leg. If I get the gurney height right, first I put tension here. Now I've got the joint under tension. But if I have the gurney right so that see my knees being bent, now I can stand up, just adding another 2 inches of length to that pull. And so really I'm using both of my thighs as the primary force to overcome their spasm in their hip. A hip is really hard to overcome when you're using your upper extremity muscles to overcome a big lower extremity dislocation. That's a setup for failure, unless you're some big muscle-bound jock. If you're a normal person, I want to use my biggest muscles to give me the strength to relocate this hip. And that's the way it works. This is not a great picture of it, but that's how it goes. What about this one? The big toe that's dislocated. These look gnarly. They stubbed it, or they were riding a bicycle and they got their foot caught under the pedal. Sometimes you'll see this with motorcycle riders, and the thing's all mangled and dislocated, and you're like, yuck. How do you get these? And the answer to this is, first, you got to immobilize the proximal part at the metatarsal. And sometimes you got to then get a good grip, and I'll use cloth or tape or whatever out. And it's pull out first, then flex down. See, that thing is off. These are usually dorsal like this. And you want to get a good hold of this on, again, I don't have it, on the proximal phalanx. You want to get a good hold of that thing, pull it out of joint further while immobilizing the proximal piece, then flex it down and relax it in. That flexion move often is what's required to get it over the rim of the tarsal metatarsal joint. These also can be satisfying. They're all a little bit rare, and so rather than do the most common dislocations here, we chose to do a few oddballs for you. If anyone has questions about these, I'm happy to do during the question and answer thing or some of these other, or just after, I can do some demonstrations for you. Thank you very much.